Okay, with more than 50 people already in the room, 53. Richard Hallinan here. I'm having the great pleasure this evening of now introducing Paul Haber, who's been chairing these seminars for quite some time, but this evening he's going to be our principal presenter on the subject, the topic you see there. And as I wrote in the flyer, these new guidelines for the treatment of alcohol problems in Australia are monumental in size and scope and scholarship, running to 300 pages of recommendations with supporting information and another 600 pages of the underlying evidence. So we hope here to distill that, some of the essence of it, at least show you how to use it, where to go, how it might be important for you. And we're planning to use a kind of question and answer format, a bit like a chat show, at least at the beginning. So Paul gave a presentation like last night with a PowerPoint. He could do that again, and we've got one in reserve, but I thought maybe because he could do it off by heart anyway, to allow him to speak perhaps with a bit of prompting, and any questions that come up in the chat, we'll try to attend to along the way. That will be the first 60 minutes. Then we have 2 case studies from registrars in southwestern Sydney, Dr Ricky Harjanto and Dr Geoff Arthurson, which I think will test the limits of these guidelines in a way that you'll see when we get there. So now Paul Haber needs no introduction. Of course, he is Clinical Director of Drug Health Services for Sydney LHD. He is a conjoint professor at the University of Sydney, and important for this event, he is the chair of the Guidelines Steering Committee for this monumental project. So my proposal for the evening is that I might ask Paul we'll look at certain questions around the why we have a need for guidelines at all and who they're for, and then move on to the how they were produced, what method and what results, and then the what's in the guidelines, what's new, what's interesting. I'd probably be asking Paul to, as it were, give us his desert island discs from this large menu, and takeaways that would be of interest to him, things that he thinks might be interesting for us, and so on. And certainly I've got a few of those myself, and we have a few questions already submitted. So now it's time to go over to Paul, and the initial question is, why do we need a new guideline like this?
Thank you, Richard, and thank you for everyone for dialing in. And I've been looking at the number of people on, and during the introduction, the number went up. So I'm hoping in the first 5 minutes of me actually speaking that the number doesn't crash away. Let me start by thanking our sponsor, Indivior, who have been sponsoring this series for several years now, and we appreciate their support. Can I start by just sharing the screen? Because I wanted to start discussing the introduction, the alcohol treatment guidelines, by just making sure everybody knows where to find them and what they are. So Richard, everyone can see that now, do you think?
Yes.
Yeah, great. So the web address is pretty simple. It's hopefully you can see it now, alcoholtreatmentguidelines.com.au. And the website has been optimized both for the large screen, you know, like your laptops and so on, as well as the small screen, so that it actually looks pretty good on your phone. You just do a web link and turn your phone on the side, and you can see it really nicely. So if you want advice on some particular point, I hope you will see this as a useful go-to kind of place. It will have these buttons on it: overview, screening, diagnosis, issues about specific populations, comorbidities, description of treatments and interventions such as the medications, and then resources including clinical tools that you can click on and download. And of course, it's all for free, paid for through your taxes. So that's the first thing. And the second little point is that if you download the address on your phone, you can save a link to the home screen on your phone, and then it basically functions like you've got a little app. Just click on that link and away you go. So hope the first point that I'm making is that the guidelines are presented in a way that is modern and easily accessible and at no cost. So I'll stop sharing now because that's really all I wanted to show you about that. So Richard said something about the how, the what and the why. Why do we need guidelines for the treatment of alcohol problems? Well, I think alcohol use disorders are probably the worst treated disorder in the whole of the textbook of medicine. So as an example, we know that the number of people being treated with antidepressants is now greater than the number of people who experience depression. And that's partly because the medications are used for more than one type of condition legitimately. But the untreated fraction is not all that great. But when it comes to treatment of alcohol use disorders, treatment is actually the exception, and only 1/3 of people with an alcohol use disorder in Australia are ever reporting that they have received treatment. And when they do, it's only after an average of 20 years. So if the disorder tends to emerge in early adult life, which is the average, 20 years later means around the age of 40. And by that time, people have experienced a great deal of harm. And by and large, they are presenting not for treatment of the disorder, but for treatment of its complications, whether it's liver disease or social disintegration, if I can oversimplify and use that word, relationship breakdowns and so on and so on. And we are therefore only really treating this disorder when serious complications emerge. And alcohol continues to be linked to over 200 medical disorders, over 150,000 hospital admissions, and something akin to 6,000 deaths per annum. And consequently, it is a huge health problem for Australia, and it is a grossly neglected one. So we think that dissemination of what is an effective approach to intervention and treatment is a useful first step. But we know that there are guidelines, if you know where to look on the internet, for kind of everything in medicine, and that doesn't mean that we treat everything energetically and effectively. And so implementation of the guidelines is critically important. And sessions like this and making the guidelines readily available, we hope will help to translate them into practice. We also want to probably next year introduce some teaching materials that reflect on things like the cases that we'll talk about tonight and help people navigate management of those cases through the use of the interventions described here.
So who do you see the guidelines intended for, Paul?
Look, they're really intended for people that treat alcohol problems, but they're not really intended for super specialists, and they don't cover every single possible wrinkle. So I'm not surprised that you're going to challenge the guidelines later this evening with cases that we may not have fully covered.
There was another question. This is a vast document, and the previous iteration of this document, 2009, had 170 odd recommendations. Now you've got twice that. It being that big, who's going to read it? Or to put it another way, are people going to read it through or read in it? What's your take on that?
I don't know that anyone's going to sort of open it up on their Christmas holiday and read it from cover to cover. But I mean, this is something that we did come up with as a question a lot. Do we have something that is short and easy to read, or do we have something that's comprehensive so that when you want to look something up, it will actually have a good chance of being covered? And we went for the latter, and we went for something that can be, even if it's big, it can be navigated through electronic searching in the same way that we use Google and the find command, which really makes it so much easier in 2021 to navigate large documents than it used to be 20 years ago.
So could we move on now to how the document was developed, I see that there's a roll call of 60 of the most prominent scholars, researchers and clinicians in the country. How did you operationalise this whole business?
Well, we set up a steering committee. We looked at the old guidelines. We did some sort of user surveys, and we first of all we hired 2 staff. So we were glad to get Ben Reardon, who is a very IT savvy young postdoc, and Dan Winter, who actually also pretty IT savvy. And we did surveys of several hundred potential users of these guidelines online. And those data helped us to understand what was good about the previous guidelines and that should not be tampered with too much, as well as what was not so fantastic. Just to give one example, the previous guidelines covered recommendations for Aboriginal people in a page and a half. And that's partly because about 15 years ago, there was an entire separate document for Aboriginal people. But still, when you looked at this document, it was a page and a half. So we, and the Commonwealth does not seem to have updated the Aboriginal specific document. And so we very significantly expanded the Aboriginal section here. And we made sure that that process was basically led by Aboriginal people. Kate Conograve chaired that group, acted as like a senior author for that group, but most of the authors on that chapter are Aboriginal people who are very experienced in managing their peers with alcohol problems. And so they firstly come up with some very good ideas, but secondly, it was a lot more comprehensive than its predecessor.
I'm sure there's much more to say about the consultation process and so on, but I imagine we can probably all imagine that. But I wanted to talk there, it's a good example about the Aboriginal chapter. One thing which I imagine must have been deliberate and is part of the how here is with the number of recommendations increasing, also in a number of chapters, the number of weak recommendations at grade D or just GMP, good medical practice, has increased. And so we find, for instance, very strong recommendations, A's and B's, about screening, brief interventions, alcohol withdrawal, pharmacotherapies, psychosocial interventions, cognitive impairment, very interesting, medical comorbidities, they're all very strong. But then we look at, but I think particularly 91 recommendations relating to specific populations based on age, sexuality, gender, cultural or ethnic identification. That's including Aboriginal and Torres Strait Islander identifications and culturally and linguistically diverse people. And those 99, 75% are grade C or less. So they seem to be expanded in amount, in number, but then they're not at very high grade. And so I'm wondering what message we can take away from that. Is it related to key uncertainties?
Well, yeah, sure. So the evidence base continues to expand, but there are so many areas with very limited research. So if you take older people, if you take Aboriginal people, if you take LGBTQI people, there's scarcely a randomized controlled trial in any of those groups. And so whilst there is good clinical practice and there are recommendations to be made, they're very infrequently are they being made on the basis of robust clinical trials. And so part of this process identifies what we don't know as much as what we do know. And another way of putting it, if the knowledge was so robust and so confident, you kind of wouldn't need guidelines all that much. It would all be obvious. It's where we are uncertain that guidelines draw together the existing evidence and and experts and good clinical sense probably adds value to our practice most significantly.
Yes, as well as pointing out areas of research need. So look, if we come to the what now, what's in the guidelines, and if I just asked you for your favourite takeouts or the things that you'd most like, I mean, you've been overseeing this whole process, so I suppose you probably aren't even allowed to have favourites, but are there any particular things you'd like to sort of point out to us that leap to mind?
Yes, well, probably the one that's that I feel most strongly about is the chapter on stigma and discrimination, because when we thought about making a chapter on that, it took us a while to find someone willing to do it, and then it took us a fair while to convince that person that there was anything to be done. But once we got the ball rolling, it was very hard to even stop, because we felt that we opened Pandora's box to some degree. And the more and more we think about it, the more and more I see that stigma is a core issue that really sits behind a lot of the problems that our patients experience, a lot of the problems our services and our staff experience, and that the field experiences. And it's very hard to completely ignore it. So there's a bunch of recommendations there about awareness and training and use of language that is not stigmatizing or degrading to people that I think is important.
I'd like to run through a few of my desert island discs, as I put it, because in preparing for this, of course, I did read through the guidelines, even as you saw, I made a little...
So 2 people have read them now.
Yeah. Well, who's the other one? Not you, sure.
I have actually read them.
Look, one of the chapters is around peer support, and look, I should actually, in this, refer to a question which came from Dr. Colin MacArthur, who's with us. So he's Director of General and Acute Care Medicine at Liverpool, and has been such a support for drug health services down there, remarkably. I don't know how we could have managed over the last decade without Colin's special input. It's like he's everywhere. And his question was, I'd like some discussion about the alcoholics who are repeatedly admitted. There are long delays in arranging IDAT. How effective is IDAT, involuntary drug and alcohol treatment? Often the admissions are repeated over a period of weeks or months, and then they tail off. So I saw the chapter on that, which was on models of care, and there were some recommendations there about stepped care and case management and assertive case management. But when it came to involuntary treatment, the recommendation of grade D is there's no improved outcomes. Have we lost? Oh, you're still there. No improved outcomes beyond the period of detention. So I wonder, Paul, whether you could just respond to Colin's question there. There's not much in the recommendations. There's a bit supporting assertive case management, a gentle support for stepped care, IDAT not really coming through with more than a rather negative recommendation. Yeah, your comment.
Yeah, so the first thing I'm trying to do is navigate to that page. Oh, where is that? Oh yeah, involuntary treatment. So first of all, just to go over what we wrote here, is that the involuntary treatment is very minimal in Australia. There are legislation in New South Wales, Victoria, Tasmania, Northern Territory, and the Northern Territory has actually closed its mandatory, it developed a mandatory treatment program under very controversial circumstances and then reduced it. And so the evidence at the time did not support improved outcomes beyond the period of detention. And you can see just by the way underneath it, we reference the managed alcohol program, which I think I'd like to make a comment about as well. But there has been more evidence surrounding the involuntary treatment, and I don't know if Mark Montebello is online at the moment. Do you think he is? I'm just going to search. He's not. Okay. Okay, because Mark Montebello is clinical director at Northern Sydney, where the urban or the metropolitan unit is actually based. And Mark gave a very nice presentation only last week about it. There has been an evaluation with a control group that showed there were reasonably sustained benefits of the managed alcohol program in the months after the actual involuntary detention itself. But the key to this is that we don't know to the extent to which that's a kind of regression to the mean. That is, people come into hospital when they get bad. Most of the time with a chronic illness, they get a bit better in the months that follow, or whether the intervention in the treatment program really makes a critical difference. And therefore it's a question of what is the control group. And there are no randomized trials, but there is a sort of a case control comparison study that is about to come out that shows that patients do improve very significantly. So I think it suggests that they do improve. Secondly, I think people know that there's very limited access with 8 beds in Orange, 4 beds in Royal North Shore, and 0 beds for Southwest Sydney or for most, for the rest of Sydney. And it's very hard to transport people from your part of town to North Shore, or from most parts of town to North Shore. We had a patient last month who was from the Redfern area and who had a bed lined up at Orange, and transporting that fellow from Redfern to Orange required 4 days in RPA hospital and a very complex process simply to transport them there in one piece, which happened. So these frequent flyers who come into hospital in a bad way, the involuntary treatment, I think, should always be reserved for those patients who we cannot engage in voluntary treatment. And that is where the rub lies, because we have very limited voluntary treatment for the advanced cases. The ministry has supported the assertive case management model of care, where in some parts of Sydney, not all parts, there is a small team that can assertively but voluntarily manage patients in the community. And we don't have good evaluation of how well that works, but there is some evidence that that can also be effective, and it is far cheaper than an involuntary treatment unit would be.
And again, only low-grade grade of recommendation on those topics in these guidelines. I wanted to move on to something quite biomedical. This is so the management of alcohol withdrawal with people who've got a previous history of severe complications, and unequivocally the recommendation is to load with 20 milligrams secondarily. Obviously there'll be caveats for certain cases, but until 60 or 80 milligrams, or until light sedation is achieved. And I remember that at RPA, when I sort of stole your protocol and took it to Southwestern Sydney, for such cases, the preference was to have 10 milligrams QID, but with a robust secondarily PRN arrangement. So that is, it seems to be quite a change. And as we are currently reviewing our own alcohol withdrawal guideline in Southwestern Sydney, I'm just wondering how, this is a strong recommendation, it's grade B. Do you expect that this will shift the landscape so that everybody's going to be doing this now? So loading severe withdrawal rather than instituting regular, which is quite a common response also.
Well, it's hard to know what's actually going to shift the grounds, but I'm going to share the screen all over again and just reflect on what we've done. So what we have done here is to identify that a loading regime would be required for subgroups of patients, just these 3 groups here. And if so, the loading regimen exactly as you just described it. If not, we recommended a fixed schedule for these groups, ambulatory cases, complex cases with polydrug withdrawal, significant mental psychiatric comorbidity, and where staff may not have the skills in implementing treatment, which might be, for example, staff in a ward of a hospital that don't do a lot of this kind of work. And failing that, a symptom-triggered regimen could be recommended. And the advantage in the more simple cases, and the advantages of a symptom-triggered regimen are that more Valium can be given on the first day when the symptoms are greatest, and less Valium will be given after the first day when the symptoms come under rapid control. And so the total duration of Valium will be reduced. So we came up with this kind of, what do you call this, an algorithm or an approach that is pretty similar to what we said 10 years ago, but I think it has been refined to a degree.
Paul, I think it's wonderful that you've now been able to clarify the question I was asking, make it clear with this flowchart, or how you'd like to call it. And above all, that you were able to get there that fast. So that means that our clinicians could also get there that fast if they're using this document the way it's intended to be.
Yeah, and on their phones.
Yeah, terrific.
Without having to navigate CAP.
The next pull out that I had was on peer support. I've just mentioned it before, but detour. And I'm not sure how new this is, but it does seem to me to have strong implications, and that is recommendation 11.1, participation in AA is an effective strategy for maintaining abstinence as a standalone or adjunctive approach, grade A evidence. And assertive referral practices to AA can improve outcomes, including abstinence, grade A. So that's pretty strong. Smart recovery may be effective. It gets a grade C. So this seems to me to give sufficient evidence that clinicians might actually incorporate a referral and a recommendation, evidence-based, to their patients to participate in 12-step. Is that new?
The evidence is not all that new, but the recommendation that we read the evidence and act on it is. So AA has been incredibly well studied, and there are RCTs that show participation's effective. Now, it is, and there's long been evidence that the longer people stick with AA, the better they do. And it's also fair to say that the longer people adhere to or stick to any treatment, the better they do. Perhaps what we've done here is emphasize that peer support is super important, that it is effective, and that we've emphasized that there is a menu of choice. And of course, as the audience will know, a lot of this stuff is now via Zoom and online because of COVID. And I'm pretty sure that post-COVID, a lot of it will continue to be available online. And that there's also there are specific online social media style peer support approaches that have also been fairly favourably reviewed. One that springs to mind is Soberistas, which were, I read an evaluation of that in a reasonable medical journal. So there are, a growing menu of opportunities, and we do recognise they're important.
I thought to pop in here a recommendation from chapter 9, which is by contrast a rather weak grade for therapeutic communities. So just to read it out, residential rehabilitation programs may be of benefit for patients with moderate to severe dependence who need a structured residential treatment setting. It's almost circular there. So AA gets an unequivocal thumbs up, but our therapeutic communities or rehabs are sitting down at grade D. Interesting. Would you care to comment on that?
Well, I think less in our clinical community, but definitely still in the public, the idea of treatment for an alcohol problem is a detoxification followed by 28 days in rehabilitation. And therefore, whilst most clinicians in practice will certainly not reach for 28 days in rehab as the first intervention, there are still people that do that. And we felt that rehabilitation and residential approaches should be reserved for the more severe case that has failed to respond to other strategies.
Yes, thanks, Paul. Look, I will move on to another little takeout for me, and with this is almost by way of proofread as well, because in chapter 19, under cognitive screening, a very interesting chapter altogether with some strong recommendations, which I think is well worth dipping into and having a read. 19.1 recommendation: all patients should be screened for cognitive impairment on treatment entry, and if cognitive impairment is actually suspected, comprehensive assessment should be conducted. I'll leave out the rest of the details there. That does contrast a little bit with recommendation 4.17 in the screening chapter, which is not quite so strong. It says that screening should be conducted if the health practitioner suspects cognitive impairment, but not on everybody, as the other recommendation did. And referral to a clinical psychologist or neuropsychologist may be appropriate. And the strength of that recommendation is GPP. So first, hats off to that chapter. I think that's really an important chapter with some good, strong recommendations. And I'm just interested in that little disjunct. Obviously, you've got 23 chapters. You're coming at many things from different directions. So I'm not surprised that there are a few things that don't quite coalesce. Would you care to comment?
Well, firstly, I'd say that cognitive impairment has not always been adequately recognised or carefully managed. And there's no doubt at all that, I mean, I've walked away from the bedside at times and not cottoned on to the fact that there was a significant cognitive impairment in the patient. And so I'm the first that needs to be told you've got to be really sensitive to it and screen for it screen formally where there's the least doubt. And we often have patients, we walk away from the bedside and I say to the registrar, maybe we should get a mocker, and then go back 2 days later and find out that the mocker was 19 or something, and realize that we were really probably under recognizing it. Even if you give it superficial reflection, you can really miss it badly. Now, I know that Nick Lidsaris is online, and Nick has really done a fair bit of work on this issue of cognitive impairment as well. Lauren Mons was the lead author of that chapter, who's worked with Nick for, I don't know, 5 to 10 years. So I don't know if Nick wanted to make any comment.
Thanks, Paul. Look, I think you're right. Cognitive screening is something we've got to I think we're all recognising we need to get better at identifying this. The challenge we always have is that when we write guidelines like this, they are oriented towards us working in the AOD sector, where, you know, our patients who turn up for our services, most of them are falling into the alcohol dependent with long histories of heavy alcohol use. That might be quite different to a GP setting, where a GP seeing someone who may not have had such severe alcohol use or for as long. So the work that various people have been doing is trying to get an understanding of what are the predictors of cognitive impairment. And we're falling back to this thing of, you know, heavy use of alcohol for example, 80 grams a day for, for long periods of time, which is not a lot by the kinds of patients who come to our services, but it's a heck of a lot if you're talking about the average GP population. And so I think we need to differentiate different levels of screening. In the AOD context, where someone is turning up for alcohol use problems, most of those patients already would tick the box of, on a screener of, have you been drinking 80 grams of alcohol or more for an extended period of time? Most of our patients tick that. So that's kind of almost the first screen, which would then suggest if you tick that box, you should probably have some formal cognitive screening like a MoCA. Or there's other tests, but recently there's been a recent meta-analysis and review done by Nikki Ridley, who's one of the co-authors on that, and highlighted that at the moment, the MoCA is as good an instrument we have for screening for cognitive impairment amongst drinkers. So in our settings, in AOD treatment settings, people turning up with alcohol use disorders, they would all pretty much tick that box of, you should probably get, some formal screening with something like a MoCA. That would be different though if we're talking to, a group of GPs where, you'd be saying to the GP, look, if the patient reports drinking more than that amount of alcohol for a long period of time, and they have other risk factors like histories of seizures, history of head injuries with loss of consciousness, they're the kinds of triggers that would make you think you should do a formal screen with something like a MoCA. And if the MoCA detects something, then you should be considering referring for more formal neuropsych assessment.
Thanks for clarifying that difference, Nick. That's important. So the screening context in general practice, chapter 4 maybe, is different from the setting of chapter 19 there. And also, you've written in the chat a distinction between residential rehab and therapeutic communities. Now,
just before you explore that,
yep,
could I just highlight to everyone online that MoCA is great. There's a public domain website, mocatest.org. There are several versions of the tests, so that if someone has done the test within the last 3 months, you can use the second version, which has got sort of overlapping but slightly different questions. But you're supposed to have done the training, which I have done. It took an hour, and you have to pay money for that training to be able to download the test. So they're sort of monetizing it a little bit, but the 1 hour training, which I think cost $200, I think it was $100 or $200. It's a little bit of a barrier for people to do that training if they're not specialists and not not in private practice or something. The other commonly used test over the years was the mini mental state, and that has also been copyrighted. So there is a little bit of a challenge in being able to access these simple instruments, which is that they're not actually public domain, strictly speaking.
Thanks. And so just back to that point, the distinction, Nick, that you made between residential rehab, is that what's referred to in recommendation 911, and how is that different from therapeutic communities?
Look, so there is a differentiation between a therapeutic community model of care from a residential rehabilitation. So residential rehabilitation is a broad concept, which means anything that is residential, long-term and involves rehabilitation. The therapeutic community, as it was originally developed and designed, and where most of the research around TCs is a very specific approach to resi rehab, and not sort of widely generalizable to all forms of resi rehabs. And the literature, the evidence base for strict TCs is limited to what is a TC model.
Okay, so we might have to go back to the evidence document just to see which is specified there. I'm sure that you've got it Right. I wanted to move on to pharmacotherapies. Paul, what's new? What's most interesting that's come out of this from your point of view?
Well, we confirmed the usefulness of the PBS listed drugs, acamprosate and naltrexone. We had no major advance on those two. They have been combined in some studies, but we found the evidence for combining them was not sufficiently robust. We looked at disulfiram, which is a tricky medication, and found less compelling evidence to support its use. And just as a footnote to the audience, disulfiram is no longer marketed in Australia, but it can still be obtained through compounding pharmacies and via SAS. So it's still obtainable, but it's actually not as easy to just write a script and send them to the chemist down the road, so to speak. And it's never been PBS listed. We explored the other medications for which there is evidence of benefit, even though they are off-label and not listed for the purpose of treating alcohol use disorder. Principally, the baclofen is the one for which there's the most research, so we did come up with some recommendations for its use, but we also had significant reservations about its use, and we highlighted the risks and complexities of using that drug and conclude that it should really be used only in specialist services. And by specialist services, I don't necessarily mean addiction medicine or psychiatrist. We acknowledge that a general practitioner who has done a lot of this and knows what he or she is doing is in that sense specialist. I don't mean necessarily a credentialed specialist, but baclofen in particular has been associated with a lot of problems, including, most seriously, including overdose, and the psychiatric comorbidity and the risk of self-harm is really quite common in this cohort. I'm surprised when I've been prescribing it and I just say, oh yes, my guidelines say I have to ask, have you ever taken an overdose or felt like you might do something to harm yourself? Surprised myself how often the answer comes back yes, in people who don't look like they're about to do anything of that kind. So it is an important consideration.
I noticed a couple of other fairly high-grade recommendations of interest, psychostimulants, methylphenidate and atomoxetine, shown to be beneficial in people with ADHD and comorbid substance use disorders, including alcohol. That's a fairly good tick. And antidepressants, in particular, sertraline, dazipramine and paroxetine, as well as naltrexone and disulfiram, may be beneficial for people with comorbid PTSD and substance use disorders. So just a couple of little gems in there when you do get a B grade of evidence, and it's nice when so much is down in the C's and the D's and just the general feeling around the room.
Yeah, so I think the key practice points about pharmacotherapies probably are more about what to not do. So we still see a fair bit of diazepam or Valium prescribing for treatment of alcohol use disorder, and we don't want people to recommend that or to do that. And treatment of alcohol use disorder with antidepressants without a mental health diagnosis, similarly, no evidence that works and some evidence that it's harmful. So depending on which medication you talk about. So there is also some advice about what to not do.
Yes, I noticed that, and I even made a remark about the benzodiazepines being contraindicated as relapse prevention agents. And with the grade good practice recommendation. And it just seemed to me that contraindicated is quite strong language when your grade of, your grade of recommendation is right at the bottom there.
Well, yeah, but don't forget, there hasn't been randomized controlled trials using benzodiazepines. So in terms of the quality of the evidence, it doesn't meet these formal criteria for high level evidence, but we've certainly seen plenty of harms and car accidents and people falling over themselves. So there's low grade, good quality evidence, I think, would be one way of putting it.
Thank you. Look, a couple of things as I come to the end of my list here, and one is it's made quite clear in cases of severe liver disease, cirrhosis, and with portal hypertension and complications, that assertive referral to liver specialist centres is required, and the hepatoma surveillance and varices surveillance and all of that. It's up there with grade A recommendations. I guess most of us who work principally out of hospitals would be pretty much aware of that, but I think I was pleased to see it up there in bold.
Yes, so as a gastroenterologist, we don't want to be referred people who have mildly abnormal liver function tests and don't have much wrong with them. But on the other side of the coin, we are concerned when people with cirrhosis are not referred, given the seriousness of that condition. And if I may say, Paul Clark, who was the lead author on that section, was a member of the Queensland group that last year published a really interesting outcome paper, which isn't in our guidelines because it only came out after we finished, but it's just worth highlighting because what they showed was the survival after admission to a hospital in Queensland with alcohol-related liver disease. The median survival, if you're admitted to a hospital in Queensland with alcoholic liver disease, is 2.5 years. And that is worse than the median survival of most of the common cancers. And it is an incredibly bad prognosis, which should trigger as assertive and comprehensive management approaches we can muster.
Thank you. Look, I've got a last word now. We might be able to finish this segment before 9 and get on the case studies early, so we can finally have dinner. There are only 2 recommendations in the last chapter, which, if I remember correctly, is about ongoing care. And so the very last recommendation in the whole document of 342 is a range of clinical strategies may be used to reduce alcohol-related harm in people who continue to drink heavily and decline treatment. That these include attending to medical, psychiatric, social, medical, legal issues, maintaining social supports, and facilitating a reduction in alcohol intake. And to me, that just sounded like singing the hymn of addiction medicine through a true biopsychosocial approach, incorporating harm reduction. And I thought a really fitting end. And I was, again, slightly disappointed to see such an overarching statement with only grade D as its report card.
Well, yeah. So there hasn't been a randomized controlled trial of taking away driver's licenses of drink drivers, has there? Right. So the grade of evidence is not going to be impressive, but we have, no doubt that that's what has to be done in some circumstances. So I think it's like that. But really, we wanted to identify in the first half of that chapter, we wanted to identify non-abstinence orientated treatment outcome goals as being important. And in the second half of the chapter, we were focusing on basically harm reduction for people that can't reduce their drinking, where the focus may be on minimising harm to others, like driver's licence, occupational exposures, child protection, as well as minimising harm to the drinker where that can be done. So we had that dual focus. And when it comes to non-abstinence outcomes, this is an area for which there is some interesting new data that we did cite. And that's from NESARC study in the United States, NESARC or NHANES study, excuse me, where patients were seen and assessed for alcohol use disorder and then were seen in the next wave, which was several years later. And of those that drank less but still drank outside guidelines, if they drank significantly less, they're far less likely to meet criteria for an alcohol use disorder. So they're far less disabled, even if they were drinking something like 4 to 6 or 7 drinks per day, an amount that nobody would recommend as a good idea, but clear evidence of benefit from reduction of drinking, even to a moderate degree. So we've incorporated that into our guidelines as possible outcome measures.
Yeah, as I said, I really like that. And I also like the fact that by addressing other things that might be more important for a patient than the direct goal of abstinence, which might be what we somehow want for them. In our service, I call that an attack from the flank. It's getting with their priorities. Sometimes you can sneak around to the abstinence issue through that.
Yeah.
Do you think we should now move on to the case studies? We've got 4 minutes. I don't see any other typed questions in the chat. We'll certainly have time for further questions about the case studies. So unless there's anything coming up.
So let me just comment on what you just said, an attack from the flank. Another way of paraphrasing that, which we do comment on in the guidelines, is about goal setting and what goal a patient might be willing to achieve. So for example, we might suggest, we might want the fellow to stop drinking so you can keep your job and keep your family. It might make obvious sense to us. He might be very motivated to keep his family, or he might be very motivated to keep his job and not his family, but he might not be motivated primarily to stop drinking, but it may be accepting that the only way to achieve the things he really does want is to moderate or stop his drinking. And so that we can identify the motivation and the goal of the patient and support and strategize to achieve that, which is kind of what you're saying, but expressed slightly differently.
So we have a question from Alison Blasey regarding cognitive testing. Do other public services have access to neuropsychologists? Maybe just a quick answer to that, Paul.
Well, limited access. You know, it's always a battle, but I think Nick Linzeris has so some access through the ACM program that gave funding that did lead to some appointment of a neuropsychologist, but we don't. I tell you who does. The involuntary treatment does. Is that what Alison was referencing? The involuntary treatment services have access to cognitive testing, and voluntary treatment services don't.
Can I add here, Paul? This is a real challenge for us in our sector, that traditional neuropsych services don't really like seeing our people much. They kind of will require things like, well, they've got to be abstinent for 6 months before we can do an assessment and so forth. Yeah. And that often is coming from their sort of traditional models. There's a number of services that employ neuropsych. So I know Hunter New England and Southeast Sydney have got neuropsychologists, and they've been able to develop far more flexible ways of working, you know, where they're not requiring 6 months of abstinence, you know, as a requirement prior to an assessment and things like that. But the real challenge is, it's not just the funding. You know, even if we all got buckets of money to go and employ them, these people don't exist in the workforce. You know, there's a very limited number of neuropsychologists. Very few of them have ever been exposed or trained around substance use related issues. And this is a real workforce need about how do we end up with a sustainable neuropsych workforce for what, because we're only starting to really take this issue of cognitive impairment, and it's not just alcohol. We see very comparable levels of cognitive impairment amongst our opiate users, amongst our methamphetamine users. So this is a widespread issue that I think the AOD sector needs to start asking questions around. If we're going to take this seriously, how do we do it? Because the neuropsych does so much more than just a good assessment. They're actually really important in then being able to work with the client and with other healthcare providers about strategies for working with these clients. Often a lot of the barriers about working with these clients emanates from their cognitive impairment and the failure of services to recognize that. You know, so we say stuff to clients about do this, do that, or, you know, and then, you know, many of them are just not even registering it. They have no way of recalling this.
Yeah,
So
I think, yeah, it's a really key challenge. We can do a lot more without specialist neuropsychologists than we currently are doing, but we can't do what we need to do without them. I think we would agree. Can I just answer a question that David Hedger has posed? David in the chat said, what would be the regimen recommended for a low to moderate alcohol withdrawal in a small hospital with staff not skilled in withdrawal management? So, I'm looking at the answer on the screen, but I realize that I'm not sharing the screen. So I'll just share, and hopefully people can see those three basic regimens put up there. And so staff not skilled in implementing symptom-triggered withdrawal, fixed dosing would be recommended. And so what that would involve is if you are admitting a patient to a small regional hospital, the GP or the doctor would make an assessment, would write down a regimen, and would review the patient as clinically required. Every day would be lovely, but it's maybe a bit optimistic. And so the nursing staff have got clear orders about what to do. If the patient is a bit more complex, we might add a little bit of PRN or as required medication on top of a base regimen of a fixed dose. So fixed dose plus PRN we might do. But if their staff are not really confident, symptom triggered doesn't go well, and front loading, if it's not severe, wouldn't be needed. So you're left in the middle.
Now, Paul, I better call the clock on you for once.
Okay.
We've got several good questions there from Sandra, from Miriam, which we might have to take on notice and answer later. But I'd like now to pass over to Ricky for his presentation. And as I said, we'll follow with Geoff's straight away. And please put your questions in chat, or hopefully we'll have 10 minutes still before 9:30 to talk about those.
Share my screen.
Thank you.
Hopefully this works. Just introduce myself while I'm just going through some IT issues. My name is Ricky, I'm one of the registrars. I work at the Liverpool Drug Health Unit. So I'm going to present a case that I encountered while working there, referred by the hospital consultation liaison team. It looks like I have to restart my Zoom to fix some security settings. So how about I hand over to Geoff and I just reconnect after he presents.
Daniel, can you show it?
Yes, yeah, Ricky, I've got your slides,
okay.
so I'll share
All right,
them.
thanks. Yeah. Let me see. Are the slides showing? Oh, there we go. All right, thanks, Daniel. So just, yeah, next slide, please. Yes, a bit of background. So this is a 50-year-old lady, had a pretty extensive history of alcohol dependence. First used at 14 years old. Stated that she felt she'd been a dependent user of alcohol for about 35 years, going up to a bottle of spirits daily, but did vary through her years. She had some interesting factoids that had come in the diagnosis. She'd been reported to have a diagnosis of alcohol-related hallucinosis. There was an episode of a query stroke where it was later determined to be a cerebellar syndrome, query Wernicke's encephalopathy. She had depression, anxiety. Most of the presentation to the hospital accompanied complications of her type 1 diabetes, where in the setting of her alcohol use, she was found to be hypoglycemic or to go into diabetic ketoacidosis. More recently, she developed a myocardial infarction while in hospital. She'd been previously an ex-smoker, but other than the alcohol use, didn't have any other substance use history of concern. So I've just listed her medications there for brevity. I might just proceed, but obviously she was on an insulin as well by way of a pump, but had been in transition with regards to that management, so self-injecting at the time. Next slide, please. So as I said, this is more of a background. So she'd been seeing her GP for psychological support over this time, had that extensive medication history as above, and had been seen in our outpatient clinic previously, and also been managed by the GP for her alcohol dependence. She'd been on a camprosate for about 18 months going on at adequate doses. She had tried naltrexone for up to a month, but ceased it as she didn't find it beneficial. And as offered by our hospital consultation liaison team, she had been seen in our outpatient specialist clinic. But isoflurane was discussed on that one occasion, but there was some concern from her perspective about adverse effects. And given all the comorbidities, noted it was probably relatively contraindicated that she commenced that. She thought about attending peer or mutual support groups in the past, but had never participated. Next slide. So in terms of the presentation that I became involved in, presented with thoughts of self-harm while intoxicated. And this was in the setting of loss of employment. She was working in aged care. Her alcohol use became problematic in that setting where she became unemployed after recognizing that that was impacting her care. And she felt more and more self-isolated. This is with the alcohol use impacting her mental health. There was some collateral history from family members who found her to be quite aggressive towards strangers, for example, in the supermarket. And this eventually led to her presenting through the hospital system. So the withdrawal care was uncomplicated in this episode. She received thiamine. She did describe similar hallucinations around objects in the room, seeing shadows, but they tended to resolve over this admission in the weeks after. So she was highly motivated for abstinence from alcohol. Her main goal was to return to a work situation where she felt she could occupy her time. Unfortunately, her confidence was low given all this treatment history, this extensive period of time being dependent, that she could achieve abstinence in a shorter amount of time. Next slide, please. So just trying to quickly wrap up the case, going on to Geoff's case. So there were multiple triggers or factors in her ongoing alcohol use. She did have significant time at home alone at the moment, being off work, and boredom was a significant problem for her. Didn't go through much of the developmental history, but she did find that alcohol was something she could attach to in a lot of periods of time in her life where she became separated from partners, where her parents were more absent. And she had these more immediate issues where she was dealing with insomnia, pain due to her diabetes and other health conditions. She had Charcot's feet and it's pretty severe osteoarthritis requiring knee replacement in the future. She'd previously tried the first-line pain medications and did not find them effective, and that was one of the barriers also in terms of returning to work. She did touch on some grief issues. It seemed to be quite profound grief related to her children who'd passed, but didn't want to elaborate on that for fear of sort of attributing her alcohol use to her children who had passed. And I do notice that she did have a family history of alcohol use, her father, I believe. So that's something that might have also underpinned her history. Next slide. So just in terms of progress, we did end up commencing her on baclofen after an extensive discussion. And we did keep in mind she did have this recent history of thoughts of self-harm. I didn't mention before, but she did have one episode in hospital where she had intentionally overdosed on insulin. But this was something, given her previous treatment history and given she was agreeing to careful monitoring, that we would be able to commence in this service. The other thing we did attempt to try was analgesia. So we did go for a third-line medication, buprenorphine, or in this case, brand name Norspan, just at a low dose of 5 micrograms per hour. And given, again, overdose concerns, I think we thought that this kind of regimen was a once-a-week patch would be safer in terms of co-administering with the baclofen. And in doing so, we tried to create an integrated care approach where we're talking about our medical issues, but in that way, also trying to introduce other services such as counseling and other support groups. Just quick fast forward. So she is currently working part-time in a role, and she's continuing on those medications as above. She did not find reaching out to a psychologist or counseling something that she felt comfortable with in that time. And I do find that she's missing some of her medications on occasion when she is working and not contactable by the clinic, but by all reports, she feels like she's doing better since she's commenced these medications.
Ricky, thank you for that whirlwind tour, because we want to keep this one short. Just could you let us know what, so there's 2 months of history here. It's relatively early.
Yeah, I think it's been about since May, so probably I've met her about 5 months ago. So 2 months of that time she's been abstinent from I can read. You
targeted the pain that was identified as a trigger for her drinking, or it might have been. Insomnia, did you also tackle that at all?
Well, we identified that insomnia was mainly related to the legs at night. There's probably some degree of neuropathy, but again, we didn't want to try to attribute too many things to the alcohol use, so we went with just a simple pain medication that would, yes, again, not ideal, but might treat the pain to an adequate degree to satisfy that trigger for the alcohol use.
Thank you. So look, we'll have a discussion of this later after Geoff's case. Geoff, can you get your slides up? We can see the slides.
So this is the story of 44-year-old Sally, not her real name, who over the course of 6 months was admitted to hospital and ICU close to 12 times, having consumed a variety of substances, but predominantly ethanol-based hand sanitizer, and each admission required a high level of support to manage the acute complications, ingestion, esophagitis, acute kidney injury, hypertension requiring pressure support.
You're cutting in and out.
Oh, it might be my headphones. Is it
That's
a
much
speech
better.
issue? Oh.
Yeah, you've just gone again. You need a better microphone.
Can you hear me now?
Yes.
Beautifully. Yep.
Is that better?
Yes.
Are you able to hear me?
Yes.
No, I'll take those.
Yes, we can.
All right. Hang on. Let me.
We can hear you very well.
Can you hear me?
Yes.
Okay, people are saying yes in the chat. I apologize if now you can hear my son screaming as he goes to bed. I've taken my headphones out. So I'll try and share my screen again. So I'm not sure how much you caught at the start, but we've got 44-year-old Sally, who over a period of 6 months came to hospital about 12 times, having ingested a variety of different substances, mostly hand sanitizer, but including some other quite toxic liquids. And whilst in hospital, she obviously required quite intensive medical support to deal with these acute issues. And even whilst in hospital, she was accessing hand sanitizer despite being in an ostensibly safe and supported environment. It's important to highlight right at the start that none of these presentations were associated with any intent to cause self-harm or suicide. And so while mental health were involved in a sort of consultative capacity, it was mostly just because generally when people ingest these kinds of substances, we assume some kind of intent to cause harm. So she came to see me in the outpatient addiction clinic in May 2021. And that's sort of where this story starts. So her substance use history predominantly focuses around alcohol use. She started drinking problematically back in about 2004 when she was 27 and was drinking 2 bottles of wine, a bottle of spirits pretty much every day for over 10 years. And during this time, a variety of different interventions were attempted, some medications, support groups, counselling, rehab, but the longest she was ever able to achieve any sort of abstinence was about a couple of months. In 2018, in response to some decline in physical health, she tried to cut down, but was still drinking every day. And in 2019, there were a few significant life events that prompted her to move in with her mother and stepfather, and finding herself unable to drink on a daily basis, switched to drinking to a binge drinking type pattern. She didn't start drinking non-potable alcoholic sources of alcoholic drinks until late 2020. Otherwise, she's a daily smoker and has been using prescribed benzodiazepines for quite extended periods of time. She's dabbled in cannabis and speed in the past, but never problematically. So she's got a diagnosis of bipolar affective disorder, and this was made when she was quite young. And some people have questioned the veracity of that diagnosis, but we're pretty confident she's got anxiety and depression. And also quite certain she's got borderline personality traits, but whether this is a full-blown disorder is a bit hard to work out. Some psychiatrists have wanted to commit to that and others have held back. There was a legitimate suicidal intentional polypharmacy overdose in mid-2020, but again, none of these more recent toxic ingestions were associated with any suicidal or self-harm intent. And sort of in relation to what was discussed earlier, we haven't, admittedly, we haven't done a mocker, but we haven't detected any intellectual disability, cognitive impairment, or acquired brain injury that might be underlying some of this. I think the best way to describe the physical health is multimorbidity. So this is a rather concise, brief list of her health problems and doesn't include any of the acute issues she experienced when in hospital with her toxic ingestions. And going with this level of multimorbidity, you can imagine she's on a bucket load of medications, which she is. And from an addiction medicine perspective, at the time she came to the clinic, she was on diazepam, acamprosate, and more recently naltrexone. Social context with Sally is quite important. So she moved in with her parents in 2019, and while they've been able to provide a very supportive and structured and supervised environment, that's resulted in quite significant carer burnout. So they describe feeling like jailers, that Sally has stolen their retirement from them, and that whilst they love her, sometimes they wish she died for the benefit of themselves and potentially herself. Apart from her parents, there's fairly limited social contacts or supports. She described having a happy childhood with no obvious trauma history. She was in quite a lengthy relationship for 30 years, but that ended in 2019, which was one of the precipitants for her moving in with her parents. She's never worked and left school in year 12 when she first became pregnant. So the question is, why is she doing this drinking? Well, she describes quite nicely an intense pit of the stomach craving and being unable to think of anything else but the alcohol, and always being on the lookout for ways to get it. She would break into her parents' room where they would lock away the alcohol. She would steal money from her parents to buy alcohol. When she found the alcohol, she would drink anything and everything until it was gone. She described enjoying the feeling of intoxication and using the alcohol and similar substances to try and change the way she felt. And when we explored those themes, she talked about boredom, isolation, sense of failure when she reflected on her life, and more recently, since being with her parents, feeling infantilized and controlled by them. So by way of a simple formulation, she meets the criteria for a severe alcohol use disorder. And like many, uses alcohol to cope with negative thoughts and feelings. She may also be trying to exert some control in an otherwise very controlled environment, and also trying to express some distress, possibly because she lacks other more appropriate ways of doing that. Specifically, why is she drinking hand sanitizer? Well, we think it's probably as simple as the fact that she didn't have access to standard conventional alcohol and she was using the next best thing. So at the start of when I saw her, we did identify some very loose goals. Her family predominantly, but her as well, wanted to aim for complete abstinence, whereas we just wanted to try and keep her out of hospital for as long as possible. She really wanted to regain trust from her family and with that regain some independence. So to try and achieve these goals, we focused on obviously her drinking and the substances that she was consuming, but realized that addressing her carer burnout, her negative ways of thinking, her coping strategies and her impulsivity would be crucial to that. So treatment was basically broken up into pharmacotherapy and counselling strategies. So right at the start, we dismissed disulfiram as an option because we just didn't believe that being on disulfiram would stop her drinking hand sanitizer, and the combination of the two plus her underlying poor health would probably just kill her. We did initially stop the acamprosate because she'd been on it for a while and didn't really think it was helping much, but we did continue the naltrexone. And here is where we sort of diverged from the guidelines a little bit. We did start on low-dose baclofen, having a long discussion about the pros and cons. And we did this knowing that her mother in particular would be taking responsibility for keeping those medications safe and dispensing them on a strict basis. So we did consider the risk of overdose. We managed to get her up to the sort of classic maximum dose of 25 milligrams 3 times a day. We stayed there nicely for a while, but then some cravings came back. So we reintroduced the acamprosate. Things were going well for a while, and then the craving intensity and frequency increased again. So we very slowly and carefully kept going up with the baclofen, using an approach, I guess, borrowed from pain medicine, where there was a PRN dose of baclofen that can be used once a day for breakthrough cravings. And if this had been used consistently for a period of time, we would add that onto the regular dose, and that would lead to a slow escalation. Quite recently, we've gone to 4 times a day dosing, just to sort of fill in some of the gaps in the afternoon where she was finding her cravings would come back quite strong. And this is in the knowledge that baclofen has a relatively short half-life. We did fiddle with her benzodiazepines, but to avoid getting in trouble for that, I won't talk too much about it because it's probably caused more, well, no less harm and certainly no particular benefit, but we have fiddled with them. In terms of the counselling, she's been engaged with formal counselling with South West Sydney Drug Health Services, and that's been quite fragmented because of COVID, but she is engaging. And informally, I've been seeing her or talking to her every single week, and this is probably a product of me not being super busy, but I've been able to engage with her for 30 to 60 minutes every single Friday since May, trying to go through some just grassroots supportive and behavioural therapy. And she's been very engaged in these sessions. We also initially provided some supportive help to her parents, particularly around sort of psychoeducation about addictions, acknowledgement of everything they've been through, and trying to realign their expectations regarding our treatment, because they were very much having an all or nothing, abstinence or failure kind of mindset, and that wasn't going to be very helpful. There have been challenges. We're quite sort of aware of the potential reliance on medication and the disincentivizing nature of medication when it comes to other longer term sort of behavioral cognitive strategies. While she's engaged well with me each week, I feel her application of some of these behavioral strategies at home has been less than perfect. And she's been very reluctant at this with me to talk about any of the cognitive aspects of her drinking. There have been a couple of adverse events. Her sleep is terrible. And it was always terrible, but certainly being on baclofen, oxazepam doesn't necessarily help with that. She started eating a lot. I'm not sure if she's displacing her drinking onto food, but she's gaining weight. And while in the past she's had problems with malnourishment, we don't want to promote any more metabolic consequences. She's had a fall and actually broke a rib from the fall. And whether that's because of the medication or other factors, probably the medication. And she did have some tinnitus, which we put down to the baclofen, but that was quite short-lived and is now resolved. But I want to finish with the successes. So this is a lady who, over a 6-month period, went to hospital 12 times and went to ICU almost 12 times. And since May this year, she hasn't touched a drop of alcohol. So this is the longest she's gone without any alcohol. She's had 2 near misses, but in comparison to past behaviour, she's been very open and honest about these, which has allowed us to explore the circumstances around those near misses. Her caregivers report significantly less stress, and she's starting to reconnect with other members of the family. Like I've emphasised, she's engaged really well with me on a weekly basis. And I think we're almost going to achieve one of her goals of regaining trust and independence. And I just wanted to highlight in a final little vignette how this came about. So quite recently, she had to attend a business in person, but due to COVID restrictions, couldn't take in someone with her. And usually a family member would always go with her to stop her stealing and drinking hand sanitizer, but this wasn't the situation. You can imagine from the moment she stepped into the building to the moment she'd left, she was surrounded by alcohol hand sanitizer and was actually expected to engage with that hand sanitizer. But she didn't touch it, she didn't steal it, she didn't drink it. And the only thing that went through her mind when she looked at the hand sanitizer was, I can't believe that I used to drink that stuff. So I think things in general have been quite successful. Thank you.
Thank you, Geoff, for that case. Now, we're going to try and only have 5 minutes now so we can get to dinner. I think the case definitely shows not only the incredible complex pharmacotherapy. By the way, most of that until Geoff took over, that's prescribed by an excellent consultant psychiatrist who'd been treating her privately for years. So that was inherited. I don't think anybody would doubt that the level of psychosocial support and counselling that you've provided and the intensity of it in this extraordinary case has been part of, so it's been the whole package. It's not just baclofen and a little bit of oxazepam. But I thought perhaps I might pass it over to Paul for any comments.
Well, it's nice to see a tough case with, if not a happy ending, at least, you know, Winston Churchill said, this is not the end, it's more than the, what is it, the end of the beginning, at least, you know, because this lady's going to go up and down for years to come. But it's great to see that she's achieving something. Baclofen has been shown to be more effective at high risk level drinkers. So the people that are drinking a real lot of alcohol, as opposed to, say, the moderate alcohol dependent of, let's say, a bottle of wine a day, the people that are drinking 2 or 3 bottles of wine a day, that sort of high level drinking, baclofen may be more effective. I think it's incredibly important to maintain long-term controlled dosing of a baclofen, because she has, I mean, I'm not a psychiatrist, but I reckon she's either got a borderline personality disorder or she's got strong borderline traits. And when she decompensates, it'll be hard and fast, and she will get into that baclofen fast. So, and it's very hard to maintain long-term, stable, controlled dispensing, particularly in someone who's, you know, older, not, you know, not a 22-year-old. So I think that's a second challenge. And I think this patient is going to wear down her clinician somewhere along the way, but it is a gratifying story that you have achieved so much in someone who had such a bad situation. And surely, did you get much story about her early childhood experiences and abuse and so forth, or do you sort of avoid that?
I personally didn't go into it too much. There were quite copious mental health admission notes that did explore it, and their comment was that she'd had a happy childhood until adolescence, which is when things sort of hit the fan and she got that diagnosis at the time of bipolar. But a lot of people have since questioned the veracity of that, because it's quite young to have bipolar, and maybe this was more borderline personality coming in. But no obvious trauma history.
Yeah.
Regarding Ricky's case, there was a question there whether opioids were involved prior to the North Span, whether a pain clinic was involved. Ricky, I don't think she was on opioid pain medication before the low dose buprenorphine.
No, she was opioid naive, and I think we went through the first line and second line options with her. Of course, we didn't go down the pathway of neuropathic pain, and of course, there's a vast menu of options in that space. Pain clinic was, I guess, briefly considered in my mind, but given the stakes, I felt like approaching the pain and sort of the quick to act first management approach would be more appropriate than waiting for a referral to a pain clinic to eventuate.
Paul, are you sort of happy with an opioid medication being used as part of the suite of management of medical comorbidities in this situation in the service of alcohol abstinence?
Well, both the cases you describe are sort of highly complex comorbidity cases for which, as you said in your introduction, you will, in the case discussion, push beyond the evidence base as outlined in the guidelines. But the principles of comprehensive assessment and a framework of management of complex comorbidity in the context of as close to a supportive continuing therapeutic relationship, I think rings through both of those cases. And someone's put in the chat what great work those registrars, Ricky and Geoff, have been doing, and how actually they've presented the cases very well too. And I think that's probably what I'm going to take away from this as much as anything else, that you've got some very fine registrars who are taking on very complex cases, and we have to integrate care as much as we can for the full range of morbidities that our patients have experienced, and that pain is a common comorbidity. It's incredibly common in patients with opiate dependence, but for any substance use disorder and alcohol use disorder, acute and chronic pain is actually, as well as cognitive impairment that's been discussed, pain problems are also often under-recognized and under-detected. And the other thing is that some of the patients with this low tolerance of a negative affect, they will, some of you guys might tolerate a certain level of pain, but some of our patients will not tolerate that pain. So what's a severe pain to you may be a very severe pain that leads to a destabilization of their substance use. So yeah, sure, go for it. It seems to work.
Paul, I'm going to be good to my promise to you to wrap this up as soon as possible after 9:30, with my thanks to Geoff, to Ricky, and to yourself, also to all participants. Geoff's responded to Nick's question there about disulfiram, and Daniel, will you be able to please just keep those questions so that we can respond to anybody that we haven't responded to during the seminar?
Yes, yeah, will do.
And with that, I think I'll just say good night, good evening to everybody, and thanks again.